Yeah, so rehabilitation is about function, right? Palliative care is really about symptom control and management, but also quality of life. So we overlap in terms of wanting to give the highest level of quality of life, even to patients who are dying. So, you know, the rehabilitation physicians in particular are experts in evaluation and diagnosis of various conditions that may not be the traditional things that a palliative care physician would look at. A sort of classic example there would be a brain tumor patient who has severe spasticity, right? So they may not be able to move their arm out or spread their legs. A rehabilitation physician can come in and make the diagnosis, which is fairly easy. They're expert at prescribing the proper medications for this, for prescribing and monitoring the proper physical therapy for this, and can even do things like giving botulinum toxin injections to help improve those, which are things that the palliative care physician might not be as well trained to do. Right. By the same token, the palliative care physician may become more comfortable with the use of high-dose opioids, more comfortable with the management of nausea and other sort of symptoms that the rehabilitation physician, you know, can do, but not nearly as effectively.
So it is kind of like an overlap.
There's a tremendous amount of overlap, but complementary skill sets. And I think, you know, my experience when I was at the Sloan Kettering Cancer Center, where we had physical, you know, we had rehabilitation medicine, we had palliative care medicine, and we had anesthesia pain management, was that we would all often share a patient, and each one would have our you know, service that we bring to the patient, and the patients were better off for it, right? So anesthesia pain will do injections that we don't do, we do injections they don't do, we're more comfortable with certain medications than them. It's very difficult because there's so much to know for one physician to have all of this funded knowledge.